So we can go ahead and get started. So this week is the start of a new topic for the month, and so the overall or umbrella topic here is acute injury care, and specifically today it's focusing on the on-field management of the acute injuries. We'll move into the next week will be modalities, followed up by early stage rehab, and then travel complications. Some of the things that you have to consider in terms of the management for these acute injuries if you're on the road. Kind of give the overview like I usually do for acute injuries. The mantra that I've adopted for myself comes from the military, and that's prioritize and execute. So it really guides your evaluation when you're thinking about the most important things first, and then you decide on what those things are, and then you move forward with it. For example, right away if there's a fracture, that athlete's getting taken out. So look for fractures. If you see a dislocation of some kind of a major limb, shoulder, for example, that athlete's going to get taken out and they're not going to be able to continue. So you're looking for these things. Severe bleeding, obviously, that's going to be emergency because that's going to be life-threatening. But some of the less severe things that you can look for later, the things that aren't going to be life or limb threatening, the things that aren't going to necessarily influence their ability to continue, you can find those things later. It's not as time sensitive. So I really like the military's mantra there of prioritize and execute. Set the priorities and look for the most dangerous things first. And then once you've gotten through that, I mean, for example, if it's a hamstring strain, does it really matter if it's the semitendinosus instead of the biceps femoris in an acute case? Probably not. You know that it's a muscle strain, and then you have to figure out how bad it is. But in terms of the fractures, for example, if you see that, like you're not even gonna take a second evaluation. You're not gonna look at their strength and range of motion. You see the fracture, you get them out of there. For the ABCs, that's the typical procedure for athletic trainers. I don't know if they preach this with physical therapists as much. Do you get much of that in your coursework?
No, I think mostly because we don't deal as much with acute stuff like you guys do. But I have taken a few CPR classes, so I've definitely heard the terminology before.
Yeah, so those are pretty common in any kind of an acute management. You're looking for those things, and generally they're going to be okay. But if you see something that's in the ABCs that's wrong, then you've got some kind of an emergency on your hands. Life over limb is always the priority there, and so if you have to do some kind of treatment on field in terms of preserving that individual's life, C-spine is a common discussion there. So if they've got some kind of a C-spine fracture, the priority is to save their life rather than their limb. So if you're worried about something like, let me think of a good example. If they've got a C-spine fracture and they lose their pulse because of it, the priority is to save their life via the CPR because they're gonna die faster from that than they would from the C-spine fracture. So they might be paralyzed, but you're gonna try to save their life there. Oh, one more person wants to join. Let me let them in real quick. Kevin, hi, welcome.
Hey, thanks for having me.
Of course, anytime. This is Dylan. Dylan was a physical therapist. What was your official title when you were with us?
I was a student of physical therapy, so I did my last clinical rotation of PT school with the first team over with Houston Dynamo, and that's where I met Matt and a few of the other guys.
Very cool. Nice to meet you.
Nice to meet you too.
Kevin, if you want to give a brief introduction, this is your first time here, so I'll get to know everybody.
It is, yeah. Thanks for having me. So I'm Kevin Maloney. I'm an athletic trainer, physical therapist based out of Houston, Texas. My full-time role is I direct a sports physical therapy residency program at Memorial Hermann, but I contract with Love Professional Volleyball and USA Gymnastics.
Very cool.
Awesome. So welcome. Just to kind of catch you up to speed. Typically the format for these, I'll go through the PowerPoint slides. There's an umbrella topic of the month, and then there's subcategories that fall within that every week that changes. And we were just going over the overview for this week's topic, which is acute management or the on-field management of acute injuries. And basically what we touched on so far was the military's mantra of prioritize and execute. So you're looking for the most dangerous things first. And if you can rule those things out, then the rest of your life can become a lot easier. Once you get through that portion and you've ruled out all of the significant things, the fractures, dislocations, severe bleeding, any kind of consciousness issue, then you can go into your risk stratification. So you can think along the lines of, okay, if it's a sprain, for example, well, how lax is that joint? Is it just a grade 1 where you've got maybe a little stretch of the ligament or maybe a little bit of inflammation going on in that ligament, but it's still rock solid? It's not a hazard. It's not going to necessarily dislocate because of it. But then you also have to consider things like functionality. If they're in so much pain that they can't move, then obviously you're going to struggle to get them to participate safely. So if they're compensating in that gait, and we talked about movement compensation a couple weeks ago, but if you're seeing that antalgic gait, then you're going to have to, obviously, that changes the risk profile in their participation. Likelihood repeat of the MOI is something that I think of a lot. So for example, an ankle sprain is probably something that they could do again. All they have to do is change directions and bam, you've rolled it yet again. Or if it's a basketball, you jump up, you land on somebody's foot, and then you rolled it again. So the likelihood of the repeat of the mechanism is something that I consider in terms of the risk profile. But then also not in terms of just the likelihood that it happens again, but if it happens again, what is the consequence of that action happening again? So if you have a partially damaged, say a grade 1, maybe a low grade 2 sprain of a lateral ankle, and they land on somebody's foot and then they roll it again, now you've got a compromised tissue that's not as strong, and then you're rolling it again, stressing it even more. Now you've got increased risk for things like an ankle dislocation. Pain management, talked on that a little bit. If they're struggling a lot with pain, then obviously that's going to impact their ability to play, even if the diagnosis is safe for them to return to sport. And then the last piece to consider is the athlete confidence. If they aren't sure that they can get back out there, and if they're questioning whether or not they can do it, it's probably better to err on the side of caution, because they're going to go out and, again, you're going to have antalgic movement. You're going to change the way that they play, which then opens them up to different types of injuries. Break this down a little bit more detail. So the ABCs we talked about, Kevin, I'm sure you've seen this 1.5 million times. Dylan said in the PT coursework, they don't necessarily get it, but when they do their CPR courses, they see a little bit of it. So airway, breathing, and circulation, that's what that acronym stands for. Every AT in the country hears this every year. But basically in our emergency action planning, these are the things that we're looking out for. These are the most critical things that we're paying attention to in any kind of a response, whether you think it's severe or not. The military has a slightly different acronym that they use that's a little bit more detailed. I actually like this a lot more because it just breaks down the depth of injuries. Typically, we aren't going to see things like this, but in the event that you do, I think it just prepares you a little bit better for what you're dealing with. The order of the acronym leads you directly into the priority and the timeliness of everything. So massive bleeding should take priority over something like a head injury, for example, because if they have massive bleeding and you don't stop the bleeding, they're going to die pretty quickly. Whereas if they have a head injury, maybe you have a little bit more time to transport them and take care of them. So the March pause is the updated acronym, but a lot of times they just follow the March. The pause is more of the care and the management side of things, but the massive bleeding is the first thing you're looking for. If there's no massive bleeding involved there, then you're checking the airway, the respiration, and then ultimately you're getting back to the same thing here with the breathing and circulation. And then it just adds the head and hypothermia. So if they have some kind of massive bleeding, it's typical that it's common that they'll go into hypothermia. So if you see some kind of massive bleeding, you're also paying attention to their body temp, trying to keep them warm if they are losing body temp. Life over limb, we talked about that already, but in the example that I listed earlier, if you've got a cardiac emergency in combination with what you suspect to be a C-spine fracture, save the individual's life before you worry about getting sued for doing CPR. Save their life. Don't worry about the C-spine fracture until you can get them to the hospital. Risk stratification, we can break this down a little bit more. It's hard I tried my best to categorize them into low risk, medium risk, and high risk, but it's hard to quantify them because it's so dependent on the nature of the sport. And Kevin, you can probably talk about this with gymnastics, right? Like there's completely different risk profile to gymnastics than there is in soccer, or what the paper from this week was a baseball breakdown. And so what is high risk for them is like, yeah, I wouldn't even blink at that if it was a soccer player, because they don't need their elbow, they don't need their shoulder. They could have a pretty significant injury, like a subluxation of the shoulder, and we could probably put them back into play, no problem. But for an overhead athlete, that's a death sentence. So what I tried to do is break it down into low risk, where you see things like contusions. You're most commonly going to return them to sport no matter where it is. Mild sprains, this is going to depend on the body part. So if you're getting some kind of an ankle sprain versus if you're getting a shoulder sprain, again, mild sprain of a shoulder could be detrimental for a baseball pitcher or overhead athlete. Volleyball players, probably you get a little bit of this, Kevin. But like a UCL, for example, would be something where even a mild sprain you might want to be careful with, versus something like a DIP sprain, where it's like, okay, I don't care what sport you play with, you're all right. For the medium risk, so if you get these more moderate to severe sprains where you start to get a little bit of that joint laxity, then you have to consider, okay, well, what's the likelihood they repeat the mechanism, and what's the damage if they do? If you suspect a higher grade 2 or a grade 3 sprain of that ligament, then they're probably likely to re-injure or increase the severity of that injury, add in other structures, things like the dislocation of fractures. And then you get the higher risk where if you see a fracture, if you see a dislocation, you need to take them out immediately. Same with concussions. It's just not worth the risk of the second impact syndrome or any kind of brain bleeding that's going on. I don't know if either of you want to add anything to the sports that you work with, or in terms of the risk stratification, how you think about it, how you return these acute cases in the sport. No, pretty similar. Cool. For the literature review for this week, pretty simple stuff. Physiopedia gave a pretty good and thorough breakdown of sport injury classification. So the links are always in the literature review. Kevin, if you want to review these later, I'll share them on my website. And then there's an article that talked about playing through pain. It was a study that was put out for collegiate athletes. Or no, they did competitive and non-competitive athletes. And they broke down basically they asked them what they thought they could return to sport with and what they would actually return to sport with. So it broke down basically their pain tolerance and their perception of risk, and then how likely they were to play through something that was considered to be risky. And a couple of interesting insights from there in terms of what athletes think about. One is obviously peer pressure. They don't want their teammates to call them soft or say like, why are you getting off the field or whatever. But the other considerations were the presence of a coach. So in recreational sports, if there wasn't a coach, players were much more likely to rule themselves out. Whereas if they had a coach or if they had an athletic trainer, they were more likely to trust their judgment on whether or not it was safe. And then they would do whatever the athletic trainer or what the coach told them, which is, I suppose, a bit dangerous if it's a coach and not necessarily an athletic trainer. But if a coach is just saying, yeah, rub some dirt on it, the athlete is going to do it, whether or not that's the right decision. And then there's a YouTube video. So all the yellow links here are videos or podcasts that I thought were valuable. So the March assessment with a demonstration of how they actually go through an evaluation for military and for trauma. And that was a really thorough breakdown in terms of what they're looking for in these emergency evaluations. And then obviously the Stop the Bleed is a pretty common course, but there's a tourniquet application YouTube demonstration. So if you see some kind of a massive bleed, say you have some kind of a complete fracture that caused maybe arterial disruption, so you get some kind of a massive bleed through the fracture, the application of a tourniquet. I don't know, do either of you carry a tourniquet with you? I do. Yeah. So especially in gymnastics where you see these awesome fractures that are terrible for the athlete, but really cool stories to tell. The tourniquet is probably necessary in that sport because you're more likely to see these really just like grotesque fractures where you get compound break of the skin or disruption of the arteries. So you've probably seen your fair share in your experience. All right, so we can get into the publication review for this week. So again, this was an epidemiology and practice review. I couldn't find the structure. I think it was more of just like a narrative review in terms of the publication. It definitely wasn't a systematic review or a meta-analysis, which is what I typically like to do, but it's kind of hard to find papers published on field management of injury. Most of it's just like, if you see a fracture, put it in a splint. It's not actually like practical information like this. So tough to find articles this week, but the one that I found was more of a narrative review and assessment of the information available. So what they were reviewing were the most common injuries for baseball players and basically what they do in managing all of those different types of injuries. And so what they found, uh, the on-field evaluation needs to have a standardized process. And so they listed out the same thing that I had earlier, which is the ABCs. So the emergency aspect of the job takes precedent over any kind of orthopedic assessment. So if somebody drops and collapses to the ground, you're not necessarily going to look at their joint range of motion for their ankle. You're going to activate the EAP and get them out of there. So for them in particular, what they were looking for were head and sternum, especially in the instance of baseball when they're getting hit by the ball. So if the pitch hits them in the head, or if it's a batter that hits the ball back up the middle of the field and it hits the pitcher, commodio cordis is in play for pitchers. If a pitcher is getting hit in the chest by the ball, it is possible to have heart stop from that. And the priority there is always the head or the sternum versus the extremity. So if they've got some kind of concomitant injury that's going on with it, say they got hit in the chest and they collapse, and while they collapse, they fall in an outstretched arm and they hurt their elbow or something crazy like that happens. The priority is not the extremity. The priority is not their circulation or their nerve sensation. The priority is saving their life. Neurovascular evaluation is an important component after you move through the ABCs and assess that they are safe. And so here you're looking for the grotesque injuries. You're looking for deformity. You're looking for discoloration, some kind of circulatory issue. You can feel for a diminished pulse if they've disrupted any kind of a circulatory structure. So, for example, if they have an anterior or an inferior dislocation of the shoulder, or if they have an elbow dislocation, then you're checking that sensation in the circulation to make sure that either the neurovascular structures weren't compromised. For the after you clear all of those, and once you determine that they are not experiencing anything significant, then you go into your functional assessment. And so that's when you can check things like range of motion, strength, power, and then you can get into your sport specific. So I'm not exactly sure. I'm not quite as well versed in the gymnastic side of things. I would imagine you want to see some kind of proprioceptive action, probably some kind of sprint or jump action. With our guys, it would be probably some kind of a sprint maneuver, some kind of a change of direction, any kind of ball work you can clear. So sport specific is obviously important here. I don't know if either of you have anything to add to the functional assessment or any experience you want to share with on-field evaluation or your sequence of ruling things out.
I just had a brief question. So we talked about the hierarchy of risk stratification, with fractures being, obviously the most at risk. In the event that you have a compound fracture, I could see how that's pretty obvious that they'd have to come out and go into an ambulance or something. But in the event that it's not a compound fracture, what other signs and symptoms are you looking for to try to rule in or rule out this person either has a fracture or they have some kind of contusion?
It can be tough for sure, like depending on the size of the fracture. Like you can have small fractures that present as a contusion. Scaphoid, in my experience, is one that's like that. So if you have some kind of a fall on an outstretched arm, especially in kids where you don't necessarily know their pain tolerance, if they fall out on their hand and they say, "Oh, my hand really hurts," they could just be babies and they could just be saying, "I have an owie." Or they might have fractured their scapula. When I was at Camp Woodward, we actually saw a kid who was in every single day. It's a week-long camp. And this kid came in every day with something new. I fell on my elbow. I fell on my shoulder. I fell on my head. I fell on everything. And so we got pretty I guess for lack of a better word, we got a bit dismissive with his complaints because he was there once a day, twice a day, 3 times a day. And the one time that we didn't take him too seriously, of course, he fractured both scaphoid bones in at the same time. He flipped over his handlebars, put his hands out, and broke both scaphoid bones at the same time. A very unlikely presentation. And you say, okay, well, maybe one hand, okay, I get it, you broke his scaphoid. But for both to happen at the same time, like, you're just thinking, okay, he fell, caught himself, scraped himself up a little bit, whatever. So the pain presentation can be a bit tricky. I would refer back to point tenderness as a primary judge. So if they're tender on the bone, that's always a red flag. But you also have to, it helps to have a bit of a clinical judgment in terms of knowing your athletes, knowing which athletes are going to deal with pain better than the others. Because then if they're usually pretty good with pain and they're raising red flags and saying this is 10 out of 10 pain, then you probably want to take a second look or be a bit more cautious there. You can sometimes feel, if it's a non-displaced fracture, you can still feel crepitus. So if you press along the bone, you can still feel some movement there, some kind of instability, even if the bone is in line. So those would be what I would be looking for. Kevin, if you have anything to add.
Yeah, for us, it's like if you provide like any sort of like axial compression, does that result in symptoms, right? So you kind of cleared like, okay, it's tender to touch. The range of motion most likely is going to be full with both, like unless it's like a fracture through the joint, like they might be able to like move it just fine, which is always a bit of concern for me. So it's like, how do you do with like axial compression and then shearing? And then really ultimately we could do like a little hop test. So like, can you hop on it? And that goes for upper extremity and gymnastics as well, is like, hey, can you provide some sort of like force through this upper extremity for us to say, okay, this is more contusion based, or is there actually bony pathology that we would need to get you screened out and referred for? So
Yeah, building on that, the Ottawa ankle rules are pretty commonly taught with athletic trainers, and so the location and the ability to walk 3 steps, those kind of rule in or rule out X-rays. It's not a perfect exam, but it can help you make that decision.
yeah, same thing like Ottawa knee rules, cervical spine rules. Dylan, you're probably familiar with those as well. Like there should be kind of pretty staples that like if you're getting any pushback from athlete or coach, parent, that it's like, hey, we've got a pretty good clinical prediction that this needs imaging, so I don't want to clear him for sport.
That answer
Right.
your
Yeah.
question?
Yeah, absolutely. And that's helpful because, like you mentioned, with the Ottawa knee rules and everything like that, it gives you a little bit of something to fall back on if there is pushback with the parents or the athletes. Like, we have pretty good evidence here that if you're pain, if you're tender and dislocation, it could be a fracture. So
Yeah, like for my practice, I've fallen out of using like a percussion hammer just because it's so unclear. Also, I've tried like in the past, like using like a thermal ultrasound like over the affected area to be like, does that bother you? So if you have an ultrasound on hand, you can use it as just another tool in your toolkit, but the clinometric properties aren't very helpful in truly distinguishing if it's is a fracture. But those have fallen a little bit out of favor for sure.
got it. And you had mentioned that sometimes range of motion can get a little bit
Yeah.
muddy. So you prefer to use like a shearing or axial load in that case?
Yeah, absolutely. Yeah. Because, like, say, I mean, depending on where the fracture is and depending on how big the fracture is, sometimes they present with full pain free range of motion with overpressure. And that's the scary ones for me and my gymnast because it's like, oh, shoot, you passed my initial assessment. Like, you might be tender over a bone. So it could be a contusion based off of what happened. But then, like, they go through full range of motion. They're like, yeah, that doesn't bother it. That doesn't bother it. I'm like, ooh, I really can't rule out that there's not a fracture there, possibly. There can be really subtle, small fractures that, are going missed from this range of motion overpressure assessment. But really, if I actually compress and then I start like shearing and torsioning, that's what will give me more stock in my decision making.
Got it. Cool. That's helpful. Thanks, guys.
Something else to be kind of mindful of while you're going through your evaluation with consideration for fracture is sometimes you're doing your special tests and you're trying to rule out something maybe ligamentous, but then they're complaining of pain on a bone or something like, and you say, do you have pain with this test? And something to be mindful of, is it truly pain from the test and which structure you're trying to look at? Or is it just pain where your hands are, where you're pressing? So just kind of clarifying with them, where do you feel that pain with all of these different tests? All right. So then moving into what their findings were for the on-field care for the different tests and the severities that they're looking for. So if you see something compromised with the ABCs, airway, breathing, circulation, you're activating the emergency action plan. In most competitive settings, you're going to have EMS on standby. But if you don't, then you're getting that call sent out and you're activating the EAP. For neurovascular, so you're seeing some kind of disruption either in the deformity, the discoloration, the sensation, or the circulation. Those could or could not be emergent depending on the presentation. So if it's mild or if it's, again, like to your point with these insignificant fractures where they're in line, you could probably just like SAM splint them and send them in for imaging on their own. They could sometimes they can even drive themselves. Whereas if it's a gross, obviously deformed or angulated fracture, you're probably going to get them splinted with an air splint and you're going to transport via EMS. So checking with the neurovascular evaluation, and if you see something, you're probably going to stabilize in one form or fashion. And then if it's a dislocation, depending on where it is, you should or should not reduce it. And so what this paper broke down was for the most common injuries, elbow dislocations, you typically can't get it reduced on field. And so they didn't suggest even trying to do an on-field reduction for the elbow dislocations. They suggested you can take them into an athletic training room and try once, but most likely it's going to need a sedative reduction. Whereas the shoulder is a little bit more mobile and you can they suggested trying one on-field reduction. And if you can't get it, then you should stabilize in place and transport to the athletic training room. And then you can try again. And if you still can't get it, then you have to refer out to the emergency room to get that sedative reduction. But depending on what the body part is, dislocations may or may not be able to be reduced especially on the field. For the functional assessment, the return to play decision is kind of what you're teasing out. And so if you're looking at things like strength and range of motion, if they're all good, if you're not suspecting any kind of larger severe injury, then it really comes down to what's their pain level, what's your diagnosis, and what's the safety. And some of the decisions that we've talked about earlier lead up to those decisions. So if it's something where you think that it's just a grade 2 ankle sprain, they could probably keep playing, but the risk is if they do it again, it gets a lot worse. So depending on your diagnosis, the pain may or may not influence it, but your diagnosis should. And then it's just at the end of the day, the safety is the priority. So if you have to err on one side, err on the side of caution rather than being an idiot, I guess. So for the actual pathologies, the epidemiology report that they were looking at, the acute injuries almost always happen via dives. So this is for outfield players where they're diving to catch a ball, or for base runners if they're diving back to a base. This is where a lot of upper extremity injuries are happening in the acute side of things for baseball. Collisions are another one, two outfielders running for the same ball, or an outfielder and an infielder running two different directions, running into each other. They look up at the sky. They're not paying attention to each other. They're both calling for it, and then they just smack into each other. There's some pretty nasty collisions where like players are diving at the same time and hit each other, where you have to really start considering for both athletes these upper extremity injuries. And then the last piece is the hit by the ball. So again, if the pitcher beans the batter and hits him in the elbow, you have to rule out a fracture there. Most of the time it's going to be a contusion, but you can pick up elbow fractures from being hit by the ball. For the shoulder, the dislocations are most common, specifically the anterior. That's unsurprising given the anatomy and the trends with other sports. So the anterior dislocation is the most common, followed by a posterior dislocation. And I was introduced to a new terminology via this paper. The posterior dislocation has a nickname of the batter's shoulder. So basically they reach for an outside pitch and it changes the angle of their shoulder, and they get just that much torque combined with reaching and the plane of movement. And basically it just causes torque at the wrong moment arm, and then it posterior dislocates. So I learned a new thing there. AC sprains or AC dislocations, they did not suggest reducing these because they will not stay down if you have damaged the AC ligament. And so if you have some kind of a significant like piano key sign where you've got an obvious deformity, don't even bother trying to reduce it. Get them a sub and get them to the doctor. Usually they're non-emergency, although I think they were saying if you have a complete dislocation of the AC joint, you can also have a compound fracture of the clavicle, which I've never seen, but they say it's rare, but it's possible. So that would be the only thing to pay attention to. So that explains pretty much all of those things. We already talked about what to do if you suspect an elbow fracture. You're splinting and sending. If it's an elbow dislocation, you should be splinting and sending, not trying to reduce it. And if it's a shoulder dislocation, you should be reducing it on field one time. If you can't get it, try it in the athletic training room again, if you have sufficient staff. This is all contextual. If you have no ATs, you're referring everything. If you have one AT, you're probably still going to refer most things because you have to watch the game. But if you have a full medical staff like they do in professional baseball or collegiate baseball, one AT can go back to the training room and then the other can stay on field. For the more chronic side of things, you're almost never going to have to manage these things on field. The only exception that I'm aware of would be the UCL with pitchers. So you could have some kind of a chronic degeneration of that ligament, and then all of a sudden it just takes one pitch or one hard throw from the outfield, and then that ligament's gone. So you can get some, I suppose, ulnar neuritis if you have same kind of a deal there with a rapid velocity throw. And that's what you see as the mechanism for these chronic injuries. They're almost always a repetitive high velocity throwing mechanism. So for the elbow, the most common is the UCL. But you can also get tendinopathies of the flexor and pronator muscles. And you can also get strains and tears of these tendons, but the most common is just going to be a tendinopathy there. The shoulder, the most common was the slap tear, and that was followed up by biceps tendinopathy. Rotator cuff tendinopathy is another big one. The rotator cuff seems to be decreasing in epidemiology, probably because of injury prevention efforts, and you're doing a lot more stretching, strengthening, risk management on the front end, whereas with the biceps, you're probably not doing quite as much. And then the slap tear is obviously just the chronic overuse of the shoulder with the extreme forces that are put through it at the extreme ranges of motion. Internal impingement is pretty common. You'll see that a lot. It's a weird thing because it's not a true diagnosis, but it's a presentation that you're going to see a lot of inflammatory conditions arise from. So internal impingement, be aware of the mechanism, but it's not a true or technical diagnosis. And then the last piece would be the scapular dyskinesis. So you're probably never going to have to pull somebody out of a game for scapular dyskinesis, but being mindful that these are something that you might have to see in the more chronic. So to wrap up, the kind of mind frame that I have when I go out on a field is prioritize and execute, find the most important things and don't miss them. And when you see the important things like the ABCs or the march or a life-threatening or emergent injury, execute those first before you worry about things like range of motion and strength. Anytime you have a loss of consciousness is going to be some kind of an emergency referral because that is a significant disruption of brain function. And you can also have life-threatening issues that are coming from it. The fractures, dislocations, and severe bleeding are always in the severe category of injury, no matter what your sport is. The other ones are sport dependent, body part dependent, and you have to make that decision with a little bit of clinical experience, knowing your sport, knowing your athlete. And then you're using things like joint laxity, functionality, and then the likelihood of the repeat mechanism, and then also the consequence of the repeat mechanism. Any questions, any last minute comments about this week's topic? No? All good? All right. Cool. So that will do it for this week. And then next week, in terms of managing these acute injuries, we'll talk through different modality options and the short-term acute inflammatory phases. Thank you both for being here and hope to see you both next week.